I would like to introduce our next panelist for today. He's none other than Dr. Farid. I think all of you know him. He's a senior consultant in NTC, and he likes all the rare and interesting things. So he specializes in sarcomas and melanomas. He did his HNDP in Mount Sinai in New York, and he has a master's in public health as well. And for all the people who need tips on PSLE, you'll be very happy to know that he was the top boy of his year. Okay, so if you need tips, please go and look for him. And he volunteers in the Migrant Workers Center and is a strong advocate for cancer in the community. So, Farid, all yours.
Thanks, Warren. Just give me a minute. I need to share my screen. Okay. Thank you, Warren. You guys can hear me well, right?
Yes, very well.
Okay, great. Thanks for the invitation to speak. My name is Farid, as Warren has said, and I'm from medical oncology. And today I'm here to talk about whether inequality matters. I thought I'd start with some questions that we may all have about inequality. I think at different times in our life, all of us would probably have thought there seems to be something fundamentally problematic with widening inequality. But it's worth asking, what exactly is it that's wrong with this inequality? Clearly it's not a good thing to be poor and destitute. But why? Why exactly is the gap between the haves and the have-nots a problem in and of itself, if it's a problem at all? Why does it matter that, Elon Musk is worth billions of dollars, hundreds of billions, in fact, I think, as long as we continue to ensure that the most vulnerable amongst us have a decent chance at thriving. Also, inequality is often framed as a complex and highly contested socioeconomic issue with multiple moving parts that's perhaps beyond the grasp of any individual. Yet, as healthcare professionals, you and I know that we interact with inequality very directly, very viscerally in our day-to-day clinical work. So is there perhaps a need for us all to improve our grasp of the broader issues so that we can better take care of our patients? I thought it useful to start things off with two quotes that offer sort of seemingly differing positions on inequality to kind of set the tone for the rest of the talk. No less a figure than our founding Prime Minister, Mr. Lee Kuan Yew, had this to say about inequality. The human being is an unequal creature. That is a fact. And we start off with that proposition. All the great religions, all the great movements, all the great political ideologies say, let us make the human being as equal as possible. In fact, he's not equal, never will be. So typically forthright, candid, perhaps even blunt statement. This is how we are, so deal with it. The French economist Thomas Piketty had perhaps a different view. And he says every human society must justify its inequalities. Unless reasons for them are found, the whole political and social edifice stands in danger of collapse. Every epoch, therefore, develops a range of contradictory discourses and ideologies for the purposes of legitimizing the inequality that already exists, or that people believe should exist. Out of the clash of contradictory discourses comes a dominant narrative or narratives which bolster the existing inequality regime. So in his view, we learn to accept the inequalities because we believe or made to believe that they are just. And this belief must be reinforced, if not, society collapses. Of course, it bears noting that these are two very different men living in very, very different eras, in very different parts of the world. And as with most quotes, what is unsaid is perhaps as important as what is said. So I hope to tease that out in today's talk. So what am I going to be talking about today? A little bit about the data, the economic data on inequality, some arguments on why it matters. I'll talk a little bit about migrant workers as the subjects of inequality in our midst. And I'll try and finish off with some ideas about what we can do at the bedside about this matter. I'd just like to say that there'll be a lot of arguments I'll make in this talk. There's not that much by way of anecdote or data. I think Sufi has gone through a lot of the nuts and bolts, but I thought it was important to clarify the philosophical positions, which I think is the area in which is most lacking in the discourse around inequality. So that would be my emphasis for today's talk. So how unequal are we? This is a map of the world, obviously, looking at GDP per capita across the world. And you can clearly see that the world is certainly very unequal, a fact that has many postulated ultimate causes, including varying endowments, geographic endowments of natural resources and environmental factors, as was discussed and described in this famous book, Guns, Germs and Steel, many years ago, which led countries to have different winners and losers when it came to plagues, wars, and the like over the years. But the way this map is relevant to today's talk is two things I'd like to emphasize. One is that one of the strongest predictors for human well-being across a variety of indicators is simply the country of birth. So this map is truly very significant in the study of differences in human flourishing. And secondly, it's also this map is also one of the key drivers of global migration, including the global market for guest workers or migrant workers, as we call them, with workers trading their labor for wages, and more affluent countries as consumers, Singapore obviously being one of them. This is a look at global inequality in a slightly different way, looking at the capture of economic growth over a period of time, in this case between 1980 to 2016. And you can see, the lowest deciles of income across the world captured about 12% of total growth in the last 40-odd years, corresponding to the rise of emerging countries like India and China. And then there's a large band of the middle deciles who stagnated, corresponding to the middle class in the West primarily. And then this is the top 1% of income earners in the world in the last 40-odd years. The top 1% divided into three columns, and they captured about 27% of total growth. So clearly a lot of inequality in the last 40-odd years, and because the shape of the curve approximates an elephant, it's called the elephant curve of inequality. And obviously this period coincides with the era of neoliberalism, where one lives and dies by the rules of the market, the exponential growth of financial industry, and the explosive rise and power of big tech corporations whose reach into our individual lives is unparalleled in human history. So clearly a lot of inequality and growing inequality in the last 40-odd years across the world. I also wanted to mention a little bit about how inequality changes in different eras. This shows the level of inequality across the 20th century and into the early years of the 21st, looking at the wealth share of the top 1% of the population. So you can see that the world was very unequal, at least in the countries that were looked at in the early part of the 20th century, with the top 1% owning up to 60% of wealth, in some countries. This was in the wake of the Industrial Revolution. And then after that, inequality gradually declined, due to the world wars, the Great Depression, and many countries' responses to these devastations, like restricting capital flows, nationalizing industries, and greater government control over the economy, leading to, in the 50s and 60s, the marginal tax rates of the top income bracket in America approaching 90%. And then after that, we come to this era, which I just described, through the elephant curve I just mentioned. The take-home message is that inequality is far from constant. The levels of inequality changes very significantly from era to era, both due to contingencies of wars and economic downturns, as well as specific government policies. So it's not in any way static. What about the economic inequality in Singapore? Well, these are data just I think published last year about income inequality in Singapore over the last 10 years. So the data are fairly favorable. There's been growth in income across all income deciles and relatively stable Gini coefficient over the last 10 years or so, well, 6-7 years or so. Just a quick word about the Gini coefficient. For those who are not familiar, essentially it plots the cumulative proportion of population ranked by income from lowest to highest against the proportion of income. And it's measured by taking, dividing the pink area by the pink plus blue area. So, the larger pink area, the higher the Gini coefficient and the higher the inequality, because clearly, with a large pink area, a very small percentage of population earns a lot of the income. It bears reminding, though, that this looks at income inequality, not wealth, and also it looks at income inequality only from work, which means it excludes income from shares, stocks, rent, royalties, capital gains, which obviously some may argue is more relevant to the income of those who earn more. But be that as it may, these are the data, from Singapore over the last 10 odd years. Next, I just want to touch a bit on, this issue of social mobility. Social mobility is arguably the single best, albeit indirect, indicator of equality of opportunity, which is obviously one of the fundamental foundation stones of meritocracy. If you assume abilities and talents to be evenly distributed across the population, then any association between social background and outcomes across generations can be inferred as evidence of lack of opportunity. How do we measure social mobility? Well, one simple way is to look at intergenerational outcomes. But a report commissioned by the World Economic Forum released early this year focused instead on drivers and enablers of relative social mobility to come up with a global social mobility score. And these are the data for Singapore. So the composite score, Singapore ranks 20th amongst 82 countries. Doing quite well on certain measures, but quite poorly on measures like fair wage distribution and social protection. This report was also able to show a nice negative correlation between social mobility and income inequality. Countries with lower income inequality have high social mobility. Now, social mobility is known to be both a cause and low social mobility is known to be both a cause and consequence of rising inequality. So, this data I expected, and I guess soft validation of the validity of this index. And Singapore, as you can see, compared against other countries, did okay. I mean, not as good as the Nordic countries and some of the other European countries, Japan, but better than other countries. This is obviously something that Sufi talked about earlier, social determinants of health, and how there is a social gradient in health. This I'm just showing data from the Mohamad review. Sir Michael Mohamad is obviously a world leader in the study of social determinants of health, and he was commissioned to look at health inequity in England, where they have developed a deprivation index, looking at income, employment, education, etc. And dividing different geographic areas of the United Kingdom into the most deprived and the least deprived areas. And the data show that patients who live in the most deprived areas had high mortality compared to the least deprived areas. This obviously is something that he's shown many times before, and is kind of accepted. Just something to bear in mind, that whenever we look at such data, we should always bear in mind that we should take into account of things that could threaten causal inference, like confounding, and the other thing is reverse causation. Low socioeconomic status can cause poor health, but poor health can also cause low socioeconomic status. Now, clearly, we can't do randomized control trials with social deprivation as the intervention. So there are many epidemiologic techniques to control for these threats to causal inference. But certainly, there's something to always bear in mind whenever we look at such data. But what about socioeconomic status and health in Singapore? I think Sufi mentioned this already, but I just wanted to highlight one or two aspects of this actual exchange between the NMP and the Ministry of Health. This is, of course, published on the Ministry of Health website. So NMP Anthea Ong actually asked specifically what is the difference in life expectancy, percentage of prevalence of chronic conditions, and acute hospital 30-day readmission rate between comparing the highest two and the lowest two deciles of income in the population. So essentially looking at the disparities in health outcomes. And actually the first line of the reply was that data on life expectancy, hospital 30-day readmissions, and prevalence of chronic conditions by income groups is not available. And subsequently, the reply goes on to mention most of the things which I think Sufi has mentioned, multiple factors influencing readmissions, some correlation with educational status. There's good access to healthcare across the board, and we should all take charge of our health. But I think it was quite telling that by our own admission, we don't have much data on health disparities by income groups in Singapore. Although there are, of course, some data, and I think I'm just showing one publication. This is by Ting Hui and Gopal and colleagues, looking at survival differences in head and neck squamous cell carcinoma patients by home size. And patients who lived in smaller homes had poorer survival, even though they were not more likely to present with advanced disease, suggesting that the survival difference was not due to delayed presentation. Again, the caveats regarding reverse causation, confounding, etc. But certainly we need more data like this across all subspecialties and subtypes of diseases. So just some tentative conclusions about inequality that I wanted to make just to end this section. Global inequality has clearly risen significantly, and this has implications for many issues which are of relevance to Singapore, including migration and migrant labor. Levels of inequality have varied across different periods. They're not static. There is a well-established social gradient of health. The inequality in Singapore is relatively stable in recent years, if not quite unsubstantial. And inequality in health in Singapore, by our own admission, we need more data. So why exactly does all this matter? Who cares about all these things? Why should we think more about such matters? Perhaps I'll start by considering some arguments from those who think that inequality doesn't really matter. It's not something we need to think about too much. A common refrain is that meritocracy is the foundation stone of our society. And certainly it should be tempered by taking care of those who are less fortunate, prioritarianism, but the fundamental bedrock of our society should be meritocracy. Egalitarianism, on the other hand, interferes with individual liberty and suppresses human agency, the human ability to chart his or her own course in life, thus obstructing human flourishing. Pursuing egalitarianism logically leads to the absurdities of leveling down. The best way to achieve equality is to make everyone poor. That's the leveling down objection. Curbing inequality would dampen economic growth, some say. Envy is not a legitimate consideration of justice. And inequality is inescapable. We can't change it. That's just the way things are. We just have to live with it. Before I address those objections, I'd just like to make a proposal for what I would sort of suggest are axioms of justice from which we can discuss these matters. First and foremost, justice is fundamental to our needs and the foundation of organized human existence. I don't think this is in question. It's certainly important to everyone in general, and specifically to the issue of inequality. Because those who think something must be done about inequality, as well as those who feel other principles like meritocracy are paramount, both argue from considerations of justice. So justice is clearly important. Second, that human beings have equal moral worth. Now, this is perhaps self-evident to some, but perhaps not necessarily to all. Although I will say that this, principle is not necessarily in tension or in opposition to those who believe humans to be inescapably unequal. Because even if we have different endowments of goods, resources, abilities, we can still emphasize equality in terms of social relations, like authority, status, standing, what is termed the difference between distributive egalitarianism and relational egalitarianism. So whether or not we promote this relational egalitarianism is an active choice. It's not a matter of a reality we must accept. And last, I would venture to suggest that the common good is critical to preserve and cultivate in a well-functioning society. This includes, what is a common good? It includes tangible public goods like air, roads, public parks, the police, as well as many intangibles, chief amongst which I would suggest to be the stockpile of trust, civic mindedness, and care and concern for fellow human beings. Now, of course, some people will say that this is just wishy-washy stuff, but I do think that it is something that is important for societies, to function properly. Now, moving forth from these axioms, I want to take a stab at evaluating the benefits and the merits and demerits, as it were, of using meritocracy as our foundation stone. Now, these are the two fundamental bedrocks of meritocracy: equality of opportunity and intergenerational social mobility. And in the best case scenario, they feed into each other in a positive feedback loop, to foster a thriving society. But problems start to arise when we characterize the successful as winners and the unsuccessful as losers, and then we try to resolve this within the larger framework of equal concern or equal moral worth and the common good. For example, taking equality of opportunity, I think Sufi touched on this a little bit. It needs to be substantive, because availability is not the same as access. There are multiple barriers that vulnerable groups face in accessing resources that are ostensibly available to them. I think the biggest barrier they face is the availability of time. People who are vulnerable have very little time to do things that we think are important for their health or for other things, because they're so busy trying to stay afloat. Then there's the issue of equal concern. There are disparities in agency, influence, and status amongst different groups of people. So if we apportion concern according to the ability and likelihood of people to protest or hold us accountable, if we take care of patients who are more likely to complain, to put it in simple terms, better than those who are not, then clearly the requirement of equal concern is violated. Then there is also an issue with intergenerational social mobility, because meritocracy does lead to the transmission of intergenerational advantage. There is a dynastic component to meritocracy, and in that one respect, it's not altogether different from aristocracy, which is obviously the system that it was designed or conceived to counter. And then there are several aspects of meritocracy that can be corrosive to the common good. For example, we tend to confuse the efficiency, which is an important aspect of meritocracy, with the sense of worthiness. Of course, we must match ability and aptitude to work. The best and most able must do the most difficult jobs. But such a process should be viewed as a purely procedurally efficient one, and as far as possible dissociated from any moral desert or worthiness attached to success and failure. Because even if there was a rational way of comparing the worth of human lives, and there probably isn't, success and failure would not be it. Then, a lot of times we have outsourced merit to the market, Instead of a priori deciding what generates meaningful value for society and then assigning a price based on that value, we use price as a measure of value, And this goes some way to explaining why the contributions of many who do clearly essential work like caregiving and teaching, for example, get undervalued relative to other more financially profitable endeavors, whatever true value they create or indeed even destroy, like speculative financiers, for example. And lastly, I would like to suggest that there is a chance that the more privileged in society, the more affluent, can start to secede from society because they need less public goods, leading to degradation of public services, less social spending, private provision of goods. So these are all threats that can erode the common good. So these are some of the problems with meritocracy, where in reality it doesn't function as well as we want it to. So going back to the sort of objections to the objectionability of inequality I raised earlier, here are some counter arguments. We have not lived up to the meritocratic ideal, ensuring substantive equality of opportunity with every generation. Additionally, the moral desert we assign to success or failure can corrode the common good, as I've described earlier. People say egalitarianism interferes with individual liberty. Well, the agency of people who don't have a lot can also be relatively curtailed without substantive equality of opportunity. And the corrosive effects of meritocracy on the common good may compromise the realization of a more complete conception of freedom. the leveling down objection is, I would suggest, essentially a straw man argument, because we can't and shouldn't eradicate inequality, but the idea is to reduce and restructure it. And that's what we want to try and achieve. For example, John Rawls, the famous political philosopher, suggested that inequality is just if and only if it serves the needs of the least advantaged in society. Curbing inequality would dampen economic growth. Well, the economic evidence would seem to suggest otherwise. Envy is certainly not a legitimate consideration of justice, but the relevant ones, as I mentioned, are equal moral worth and the common good. And as we've seen, the historical record has demonstrated that levels of inequality actually fluctuate significantly during different eras, due to many reasons, of course. But there isn't any real evidence that levels of inequality stay equal throughout. So I wanted to just switch gears a little bit and talk about, talk a little bit about migrant workers as a group of people who may be on the wrong end of inequality in our midst. I thought it, useful to try and consider the position of migrant workers, on this conceptual graph that I kind of came up with, plotting on the x-axis, the duration of stay in a country, and on the y-axis, the social goods that different groups of people have access to, namely societal integration, healthcare access, and political representation. So generally, different groups, exist on a straight line. Tourists, obviously stay for a very short time, and they have virtually no access to social goods, in the country that they visit, compared to citizens and PRs on the other end of the spectrum. And along that line, exchange students, refugees, skilled foreign talent. But low-wage migrant workers do not, I think we all agree, exist along that line. They stay for a very long time, do a lot of work, but have very limited access to the social goods that I mentioned. Certainly, they have no political representation in the receiving societies. And some will say, well, that's the way it should be, because they remit money back to their home countries. That constitutes an economic loss. They don't pay any taxes, so they don't deserve these social goods. And if they have non-work, if they don't have any injuries, they have healthcare problems that are not related to injuries, then that's not the responsibility of the receiving society. Now, these can certainly be countered, I would suggest. There are certainly some data to suggest that even just looking at purely transactionally, there's economic net gain to the receiving country by having migrant workers around. You could certainly argue that the levies paid out by their employers for employing them can constitute taxes on their income. And there is a self-defeating welfare loss from unmanaged conditions. If they're not healthy, they can't work. And above all that, I think we need to think very hard about whether there should be limits to a purely transactional approach when we aim to decide what is the proper manner to treat fellow human beings living and working amongst us. Surely there must be some moral limits to such a purely transactional approach. This is a publication by Sean Vasu and colleagues that was published, I think, last year, looking at it was a survey of the knowledge of doctors regarding rules about migrant workers. And, the results are pretty telling. I think the knowledge was not very good at all. Only 50%, for example, knew that migrant workers' health insurance typically does not cover outpatient healthcare costs. That was false. About 67% knew that employers are ultimately responsible for migrant workers' healthcare costs, whether or not they were work-related. And you could argue that the level of knowledge is commensurate with, how much, what repercussions you have for not knowing these things, right? Which are, there are virtually no repercussions for doctors not knowing much about the rules around migrant workers. And I thought it would be useful to kind of sort of fleshen this out by a schematic to show the relational dynamics in migrant worker healthcare when they fall ill. First and foremost, I think we should all realize that migrant workers have a dual relationship with their employers. One is that of a boss and subordinate, but there is also the relationship between a guardian and his ward. Now, this is clearly a very abnormal relationship, which most of us don't have. It's clearly laden with potential conflicts, given that an employer who seeks to maximize labor output needs to, at the same time, care for the non-work related health of his worker. It's a conflict of interest that comes to a head if and when the migrant worker falls ill, not from injury. When a migrant worker does fall ill, then he gets care from physicians. Again, this relationship is more asymmetric than it is for fully integrated members of society who are more familiar with the system and know how to seek redress if issues arise. If it's a serious illness, when the bills start mounting, and the 15K inpatient insurance cap is exceeded, then a tug of war starts to arise between the the healthcare facility, the employees, and the medical practitioner. A tug of war that I've been involved in more times than I would like to have liked, to be honest. But anyway, essentially, there is a pushback from all the parties when it comes to managing the migrant workers' healthcare once the bills start mounting. Although, by law, the employee is expected to foot the bill, whatever the illness. And one reason this dynamic arises is because these three parties, employers, healthcare facility, medical practitioners, as I showed earlier, they are on equal social footing. They have equal access to redress, representation, whenever they feel that anything is unjust. Whereas the migrant workers are a social underclass, and they represent the path of least resistance for resolution of this conflict, without, I would venture to suggest, much repercussions for the three parties here, whatever the outcome for the migrant worker. So the doctor is a real keystone or gatekeeper for the health and well-being of the migrant worker. And that's something that I think we should all bear in mind whenever we treat migrant workers. I'd just like to mention a few things about considerations of justice when it comes to migrant worker healthcare. Just one line about global inequality and how it feeds into this. On the one hand, people will say guest worker programs, migrant worker programs allow some measure of global redistribution, because these workers work in more affluent countries, they remit money to their home countries, there is some income flow, in a way that is redistributed. On the other hand, they do not address and perhaps reinforce the structural factors, power asymmetries that contribute to the lack of equal concern for these workers. So it is not, there are certainly problems with the issue at a global level that obviously needs to be tackled as well. It also bears mentioning, I think we should all, not shirk away from this, the economic logic of guest worker programs requires migrant workers to occupy a status of underprivileged, because if they were afforded the full complement of rights and privileges enjoyed by citizens, then the very value proposition of migrant labor is undermined, and this clearly increases the probability of exploitation and domination. I thought it was important also to address this thing that I often hear from others, that they came here of their own volition, voluntarily, so if they don't like it, they could have chosen not to come, or they could leave. I think this is inadequate and irrelevant, actually, because they start from a position of considerable weakness, given the initial circumstances, and at the mercy of people with more information and power than them at every step of the way. There's no real choice between equal alternatives at any step of the way. In fact, when they, once they arrive here, there's no way they can unilaterally change their jobs. And then there's also the issue about, which I raised earlier, the moral limits of markets, about adopting a purely transactional approach. We regularly impose limits on market forces to preserve the integrity of critical societal norms, obviously we don't allow trading in organs, human organs, for obvious reasons. Although if it was purely a market-based logic, it would make sense. So characterizing migrant worker issues as purely transactional is somewhat, disingenuous, I would say, because it avoids the real discussion about basic standards and norms. Finally, I'd like to touch a bit about what we can do at the bedside. Just some ideas and some thoughts. Again, Sir Michael Marmot, he came out with this declaration of Oslo to get clinicians or physicians to think a bit about health equity. A few of these things, workforce education and all that. I thought I'd just highlight two things. One is that the one highlighted, working with individuals and communities. As Sophie has shown very nicely, at the end of the day, a patient's health is inextricably entwined with the social environment. So we need to expand the bedside. We need to actively think about this every time we see a patient in the ward. And I'm reminding myself as much as anyone else, the health doesn't begin and end, begin at admission and end at discharge. Clearly, it seems sort of absurd to think otherwise, but I think it does bear reminding. The other big piece, I think, is the health sector, is how we structure our working environment. Firstly, we should embody equitable practices, even amongst colleagues, amongst colleagues at different levels of seniority, but even more importantly, I think we should support each other to act for health equity, because it is challenging and tiring, and we can all too easily slip into rationalizing unequal concern. So that's something that we need to support each other to pursue health equity. I'd just like to mention just a few reminders for daily practice, again, as much to myself as to everyone else. Healthcare provision without health improvement is meaningless. Inequality, I think we all know that. And inequality accounts for a substantial portion of this gap. As physicians, we interact directly and intimately with inequality constantly. This unique access is an opportunity to study it and clarify its impact, a responsibility to mitigate its ill effects on health, and a challenge to stay true to our fundamental duties of care. I think when the underprivileged interact with doctors, the equal concern we provide them is unique. It's uncommon in their lives, and it's something very precious to both us and them, which we should cherish and preserve. And I'd just like to sort of suggest that our duties to individual patients and the wider society, which is to preserve the principal public good of trust, neatly converge when we actively strive for equitable health delivery, as opposed to just equal healthcare provision in our day-to-day practice. This bank of public trust in the integrity and impartiality of physicians is probably the most precious resource we have, whose loss cannot be easily quantified in the short term, but whose longer-term corrosive effects can be easily appreciated. Many things like lower trust in doctors' advice, litigation, and the like. So this issue of public trust is critical, and striving for health equity is one of the best ways to preserve that trust. Finally, I'd just like to finish with some final take-home messages. I think it's important to realize, or at least I think so, issues of justice, ethics, and professionalism require clarity of thinking as much as, if not more than, compassion, because with normative positions clear and actively adopted, rather than muddled and passively accepted. Philosophical introspection cannot provide empirical evidence, but its emphasis on internal consistency is one safeguard against self-deception and injustice. I like to say that I think the rules of the social world are largely not fundamental laws of nature, but they're designed and thus potentially malleable. Inequality may have been the case for most of civilization, but emphasizing equality of social relations, again, relational egalitarianism, not necessarily distributive, was a form of moral progress in concert with all our technological and material progress we have achieved, which we should cherish and uphold. Inequality matters if we accept the truth of equal moral worth and the importance of the common good. It matters because we are all only as safe as the most vulnerable within our midst, and nature cannot be fooled. I don't think we need to be reminded that in a year 2020, when a strand of RNA brought the entire human race to its knees, it would do us well to remember that, as we have learned right here in Singapore, that we are only as safe as the most vulnerable amongst us. And inequality matters because we are duty-bound to patients and our profession, as well as because trust is priceless to the practice of medicine and the thriving of society. So that's all I have to say. Thank you very much, and I'll be happy to take some questions.